Welcome. My name is Jan Kaminsky. I'm a colorectal surgeon at Illinois Masonic, and I want to welcome you to our panel discussion for colorectal cancer. For COVID precautions, all of our panelists have been vaccinated, and we've taken all the appropriate precautions for COVID-19. And that's why all of our panelists don't have masks. As you may know, March is our colon cancer awareness month. We have over 150,000 patients diagnosed every year in this country for colorectal cancer. 50,000 of them will die from that. We're very privileged to work at a system that has been nationally recognized for our screening efforts in 2018 for colon cancer, as well as we've been nationally recognized for a Center of Excellence for rectal cancer. And in large part, that's because of the panelists that we have here and the specialists that we have here. We're very lucky, and I'm very privileged to be moderating this panel of specialists. Our goal is to discuss evaluation, management, and treatment options for colorectal cancer, and we'll get direct answers from the specialists who deal with this every day. And another disclosure, there's no relevant financial disclosures from myself or all the panelists. So without further ado, I'd like to introduce everyone on the panel, or them introduce themselves. And we'll start off with Dr. Albert.
Hello, my name is Dr. Andrew Albert. I am a gastroenterologist and also medical director of digestive health here at Advocate Illinois Masonic Medical Center.
And we'll move to Dr. Chavinsky.
I'm Dr. Aaron Chavinsky. I'm the Director of Surgical Oncology and Program Director of the Surgical Oncology Fellowship at Aurora St. Luke's Medical Center in Milwaukee, Wisconsin.
And Dr. Weisenberg?
I'm Elliot Weisenberg. I'm one of 5 pathologists at Illinois Masonic, and we all share the GI pathology duties, but with Dr. Manta Pant, we do the GI and rectal tumor boards, where we get our expertise, although Dr. Pant is fellowship trained in GI pathology.
Wonderful. Then Dr. Aklilu?
Hi, my name is Meva Aklilu. I'm one of the medical oncologists here at Illinois Masonic.
Dr. Jim Ruffer?
How do you do? Dr. Jim Ruffer. I'm one of the radiation oncologists at Illinois Masonic and part of a large group and one of just many outstanding radiation oncologists across the Advocate Aurora system.
And last but certainly not least, Dr. Bask.
Hi, I'm Kyle Bask. I'm one of the radiologists here at Illinois Masonic, and one of my main clinical areas of focus is GI imaging.
So wonderful. Thank you all again for being here. And we can probably get started. So the first question will be, what is colon cancer? What is the pathophysiology of colon cancer? Why do people get it? And I think the first person to start that conversation should be our pathologist, Dr. Weisenberg.
Okay, well, I'll just try and run through what we do when confronted with a colorectal malignancy or a precursor lesion. At its very basics, colorectal carcinoma is a malignancy of the glandular cells that are found in the large intestine. There are other malignancies, but when we say colorectal carcinoma, we're basically saying adenocarcinoma. And, a lot of, what's going on with pathology isn't well understood. We're sort of the black box, the weird people in the laboratory, so I'll try and shed a little light on who we are and what we're doing. So the first thing, of course, is to make a diagnosis. A clinician gives us some tissue. We're going to try and figure out what it is. So narrowing the focus when we're dealing with colorectal adenocarcinoma, we're going to prognosticate it. So the TNM staging, which if you're not familiar with, is tumor nodes and metastasis, is going to guide how prognosis and and treatment. So usually when we make a diagnosis of colorectal carcinoma, it's going to be on a biopsy, say Dr. Albert or one of his colleagues gives us. And just focusing now on polyps, first off, what kind of polyp it is. Is it a hyperplastic polyp, which is benign? Is it adenomatous, which is a non-obligate precursor to the development of colorectal carcinoma? Sessile serrated adenoma or polyp, it goes by a different pathway. Could it be something else? Could it be, say, a neuroendocrine tumor? And importantly, is a polyp malignant? So if it is a malignant polyp, we need to determine whether the polypectomy is curative or whether the patient needs additional surgery. And we'll do that with looking at the margin, the grade, looking for something called lymphovascular space invasion and how deeply the polyp involves. And then first, is it cancer? And if it is malignant, could it be something else? Could it be, say, a melanoma or a lymphoma or something? The vast majority of the time, we're just dotting the I's and crossing the T's. Dr. Albert, Dr. Javinsky knows what they're dealing with, but there are very, very rare times they're surprised. So this is a typical endoscopic picture of a small polyp, and you can see to the right of the screen an adenomatous polyp. The nuclei are a little bigger, a little darker. There's mucin loss compared to the normal there. I'm not going to turn you all into histopathologists today, but I will tell you a little story about this. The polyp you're looking at is mine. And I started screening when I was 40, and the reason is because my father had one colonoscopy in his life, and that was when he was 69, and that was what a stage 4 colon cancer was diagnosed. He refused to be screened. The only colonoscopy he had was diagnosing that, and this goes to show just how important screening is. He didn't have to die. Now, the vast majority of colorectal carcinomas come from what's called the APC-WNT pathway, and these are more likely to be on the left. And what you're seeing is a typical histology for colorectal carcinoma, has this, what we call a Garland pattern with this loops and loops and loops of cancer, and then often dirty necrosis. And so the key point here, and why this is important in screening and detecting cancers before they can become cancers, is that adenomas are non-obligate precursors to the development of adenocarcinoma. We don't know which ones are going to progress. The bigger they are, the more likely. But that little tiny adenoma that you saw from me, if that's removed, it's not going to get the chance to become a colon cancer. These mutations will sequentially accumulate, and as we go from small adenomas to big adenomas to cancer, there's more and more of them. It's thought that most adenomas take about 10 years to become a cancer if they're going to become a cancer. So that's the window, and that's when screening can work. Some, unfortunately, cancers don't read the rule book, and that's when we can see these tragedies like colon cancers in young people. So this has been sort of a crash course, if you'll forgive the pun here, in what pathologists do when we're encountered colorectal carcinoma.
Right, so we talked about pathology and how we kind of get there, that we have environmental and the genetic factors of why people get this colon cancer. But how do we actually diagnose it? How do we, what are this kind of screening guidelines that we should be telling our patients? I'll let Dr. Chavinsky probably start.
Yeah, and then Dr. Albert will pick up from me. So the most important thing I'm going to say about screening is for patients who have no family history of colorectal cancer and are not having symptoms. They're not having pain, they're not having blood in their stool, they're not having cramps or other symptoms. So the screening strategies I'm going to talk about at this point are going to be for patients who are asymptomatic. They're off the street, they have no complaints. So don't mistake screening for the evaluation of somebody who may have a symptom, because they're completely different pathways. And so we're going to talk a little bit about some of the newer and recently changed guidelines for the screening strategies for colorectal cancer. And next slide. So the USPSTF guidelines suggest that starting screening at age 50 would be appropriate. And that was the guideline until about the end of 2020, where they changed the guidelines and suggested that starting screening at an earlier age, starting at age 45, would be appropriate. And that's the guideline that most people are going to now follow. Now, sometimes some of the insurance companies haven't quite caught up to that yet. But the recommendation from our system is that we should consider screening starting at age 45 in the asymptomatic individual without a family history. If you have a family history of colon cancer, you should really start screening 10 years before the youngest person in your family has developed cancer. The American Cancer Society has also recommended that people at average risk of colon cancer start regular screening at age 45. And again, talking about either a stool-based test or a direct visualization test. They recommend that people in good health and with a life expectancy of more than 10 years should continue regular screening through the age of 75, and people 76 through 85, that should be a shared decision-making between the patient and the physician. And over 85, they should no longer get colorectal cancer screening. And again, the USPSTF guidelines kind of terminate at age 75 and don't go beyond that. And I'm going to turn it over to Dr. Albert to further elaborate on what I just said.
I did have a question for Dr. Albert, and just because I'm curious, why would the national guidelines change to decrease the age from age 50 to age 45?
So most recently, there was a study put out in part with the American Cancer Society that suggested that performing colonoscopy as early as 45 will decrease the risk of colon cancer in the age group from 50 to 54. And anyone who wants to weigh in on that is welcome to do so. But because there was such an impact on the reduction of colon cancer in that group or finding of polyps in the 50 to 54 age group, they started screening earlier at 45 years old.
Now,
just one comment to that.
yes.
Several studies have demonstrated that colon cancer demographics are starting at an earlier age, and we're seeing both anecdotally and by study earlier age diagnosis of colon cancer.
Right. So, the incidence of colorectal cancer is actually decreasing overall. But like Dr. Shavinsky said, the incidence of colorectal cancer in people under 50 is actually increasing. So, Dr. Aklilu, why is that?
I think I would get the Nobel Prize if I can answer that. But it is a really interesting question. And so I don't think the answer for it is purely genetics. And so there are genetic syndromes that predispose patients to a younger age group. But what we're seeing is that this doesn't fully explain that rise in incidence in patients in their 30s and 40s. I think, personally, I don't think there are data that is evolving, and I think people are trying to answer that question. But I think that it's probably some environmental factor that is playing a role here, whether it is some processed foods or environmental chemicals that we all lived in at that younger age group that took a little while to percolate in our system to manifest itself. But I think that is a better explanation. I think there is some environmental exposure, some genetic, kind of epigenetic predisposition that is required for that environmental exposure for us to see this change. But it's a true finding that I'm seeing in my clinic, and every 30-year-old that you see rings out, and I'm seeing more 30-year-olds with cancer that are coming in, and so it's a true finding.
Yeah, it's scary. And, I was looking at the recent statistics about weight in America. I think just over 40% of us are obese, which is BMI of over 30, and over 70% of us are overweight, which is which is BMI of over 25. So I'm curious, in your clinical practice, Dr. Ruffer, have you seen that change in your patients over the years?
Over the years, what we've noticed in radiation oncology is our patient populations have been getting larger. When I started this in the dark ages, but after Elliot, it was the rare patient who hit our table limit in regard to size. And our table limit used to be about 350 pounds. That table limit has increased, and it is our experience across all of our sites that actually is something that we've needed. Because the size of patients, and this is across the board, not just the colorectal population, has been getting larger, reflecting the population in the United States.
And, Dr. Weisenberg, does obesity factor into a risk of colon cancer?
That has been shown. The major risk factors, probably the most important would be family history and, syndromic conditions, but also fat in the diet, fiber in the diet, diet high in fresh fruits and vegetables is somewhat protective. There may be a role in some situations for NSAIDs in prevention. I know it's been done in some familial adenomatous polyposis patients. Sedentary lifestyle is associated with higher risk. It's a lot of things, but our couch potato fast food lifestyle, the Western diet, and that's also involved in the increasing incidence of colorectal carcinoma in the developing world, which is very distressing.
So kind of going back to our diagnosis, because we've kind of talked about the endoscopic things, the endoscopy role in diagnosis, the stool test, which we'll actually go back to. But I wanted to ask Dr. Bass, what's the role of CT colonography in diagnosing colorectal cancer?
So the role is presently emerging as time goes on. So as we've seen in the recommendations, it is an option for screening asymptomatic patients who do not want to get a colonoscopy or can't get a colonoscopy for some reason. CT colonography really has no role in patients who are at higher risk intrinsically, like syndromic patients. But for an average risk patient, CT colonography is an option. Basically what it is, it's just a fancy CT abdomen and pelvis where the patient is prepared beforehand, and then you place a rectal tube and insufflate the colon with air, and then using fancy software, this is turned into a three-dimensional virtual fly-through of the colon, and this can be read in a similar way to a conventional colonoscopy. There are some good advantages to CT colonography. Probably the biggest one is that it's less invasive than colonoscopy and doesn't require any anesthesia. So for patients who are unable to or unwilling to go through the full colonoscopy, it is an option. It also is helpful in patients who have discovered an obstructing mass and a colonoscopy can't get past that mass. The CT colonography actually is able to usually get good imaging past that site, so that's one option. The drawbacks for CT colonography is, as was mentioned before, if you find an abnormality, you have to go quickly to colonoscopy to actually address that abnormality, to get sampling of it and make the diagnosis. It's also, from a structural standpoint, it's a bit tricky to have it get done just because insurance companies are not always on board on having CT colonography done, and the test is not widely available among all centers. You need to have kind of a specialized center that does a large volume. They have to have the special software and the special equipment. So those are important drawbacks for that. So bottom line, CT colonography is an option for screening, and as time goes on, it might have a greater role, but for now, it's not as commonly used as other methods.
Can you diagnose colon cancer with a CT scan?
So the answer is yes, with an asterisk next to that yes. So a conventional CT scan CT abdomen pelvis that's done for a patient who has symptoms, who comes to the emergency room, who has abdominal pain, signs of obstruction, rectal bleeding, that sort of thing. So oftentimes you will see the colon cancer, and you can make a strong supposition that that's what the diagnosis is, although to actually make the diagnosis, you need to have histology. Having said that, for CT abdomen pelvis is not a screening test, and it's going to miss a lot of small colon cancers, especially because most CT abdomen pelvis patient has not undergone any sort of colon prep, and so small lesions are going to be obscured by bowel material. So the answer is yes, we can and do see colon cancer on CT abdomen pelvis. Usually it's larger tumors that are causing symptoms, and it has no role in screening, but we do see it.
Okay, and going back to screening, we have a panel of specialists who deal with colorectal cancer as their primary job. My question is, first, what would you want as a screening option for yourself? And what would you want for a screening option for your wife? Dr. Albert, we'll start with you.
So I just want to point out that I'm a little bit biased as a gastroenterologist. I think all roads lead back to the colonoscopy. So I appreciate the various options, and I just want to say that the best test is a test that gets done. We say this in our American Cancer Society meetings often. The test of choice that we feel is the best is the colonoscopy. But right now, during COVID and during all the difficult times of screening, really it is any test, whether it's a stool-based test or a CT colonography or a colonoscopy. I would say whatever test the patient would be willing to do would be a great first step. My wife and I have had our colonoscopies, so we not only do we feel they're the best tests, but we've had them. And so that's where we stand.
Colonoscopy. Okay, Dr. Shavinsky?
I've had my colonoscopy too.
And how about your wife?
My wife is a little bit more reticent. Hasn't decided what she wants yet, is thinking about doing a Cologuard, as Dr. Albert said about the test that gets done. But I'm a big believer, I always have been, in colonoscopy for a number of reasons. As I mentioned before, it's a one-time, one-step test in general for most people, so that you do the test, you get the diagnosis, and often can get the treatment in one sitting. With big risk, with big reward comes big risk, and there's more risk to colonoscopy than most every other test available. But that risk is really mitigated extremely low in expert hands. In a scheduled colonoscopy, the risk of perforation or of complications is exceedingly low.
What's the number?
Dr. Albert?
So I believe it's 1 in 10,000 or 1 out of 10,000 to 1 in 100,000 risk of perforation. But I do want to just put a plug in to say that it's important that the providers discuss the low risk aspect of it, because patients oftentimes have heard things or have worries about the procedure. So just bringing up the topic and offering to talk about it a little bit more in detail would be very helpful.
Dr. Weisenberg.
Well, I'm high risk, so it's colonoscopy for me. And for my wife, she's colonoscopy. At one point, she did have a Cologuard because difficult scheduling, things like that. It's worth pointing out, and I think I speak for most people who've had colonoscopy, when you get up from the Mac, you feel great. I mean,
Best nap of your life. That's what I tell my patients. Dr. Aklilu.
So I should be getting a colonoscopy. I'm due for a colonoscopy. I have been putting it off just because I'm not very good at taking days off. That's my biggest issue.
Yes, we know this.
So I'm due for a colonoscopy, and that's the one that I think that's reasonable for me. Sadly, my wife is considered high risk. Her family's been ravaged with colorectal cancer, and so she had one at a young age and continues to get colonoscopies.
Okay. Dr. Ruffer.
9:30 a.m. on a Monday in mid-April, I'm already scheduled. And
Beautiful. Look at these examples. It's perfect.
and my spouse, the same. She has regular colonoscopies.
Dr. Bass?
So I'm not quite in the screening quite yet, but when it comes, I mean, based on what all my colleagues have been saying, it's going to be colonoscopy for me and my family members, unless there's some strong conflict. But that should be the default.
And I'm with the entire panel that colonoscopy is
And
for
you?
me and the wife. Yeah, my wife already had her colonoscopy. I'm going to have mine in a few years. So that's for our patients, right? So this is the entire panelist is saying that colonoscopy is their preferred method. How about the patient who just doesn't want to get tested? They don't want to do anything. What do you say to them, Dr. Albert?
So I say to them that the most common symptom of colon cancer is no symptom at all, and that's a fact. Usually when people are more advanced, they have symptoms. I basically give them options. I very much promote the stool-based testing, whether it's the multivariate DNA testing or the blood testing in the stool. But a stool test is definitely something I lean heavily on because I feel that everybody needs to be tested, especially over the age of 45, for colon cancer for screening purposes, not diagnostic, as Dr. Shavinsky was mentioning, but for screening purposes. So I offer the stool test, and oftentimes, if they push back, I will ask them questions about why and sort of undo these misperceptions or these misunderstandings, because I hear often, I poop good, I eat good, I feel good, why do I need to get a test? And the reality is that you need people to understand that the growths or the colon polyps don't cause symptoms and that you would never know that you had them unless you check for them. And that 1 in 22 people, which I think is important to mention today, get colon cancer. And 90 to 95% of those cases are fully preventable, with the exception of some cases. So it would be a shame not to educate the patient on those statistics and make it clear that this is very important. I think people don't really want to talk about the colon and the colon health, but the reality is it has to be talked about, it has to be addressed, because innocent lives will be affected. And so I try to basically break down all the misunderstandings and provide as much information as I can in that limited period. And hope that they will consider.
So Cologuard is kind of a relatively new test, and it's been kind of talked about. I've had some of my colleagues ask about it. I know patients have been asking about it. How do you talk to your patient about somebody who's asking for Cologuard? What do you tell them? What is it, and the specificity, sensitivity? How do you talk about that?
So I just mentioned that the test is around 92% sensitive. It checks for abnormal DNA in your stool, which is indicative of polyps or cancer, both. It's not just a colon cancer test. It's a test that also checks for polyps, which are precursors to colon cancer. I explained that it's a 3-year wait. If the test is negative, it's 3 years until your next one, whereas the FIT test is a year only. But if it is positive, then you are going to need a colonoscopy and explain why that is the case. Now, one thing I will say about Cologuard that's important is that it is not to be used on patients who have had polyps in the past. The screening guideline for colon cancer for people who have had polyps is colonoscopy. It is not FIT test. It is not Cologuard or stool testing or CT colonography, although I appreciate the CT colonography. It is a colonoscopy because now you're not considered average risk anymore. You're higher risk because you've had polyps.
How about if a family history, isn't it also not good?
Also, thank you, Elliot. Yes, if there's a family history or inflammatory bowel disease or higher risk case, colonoscopy is the gold standard of care. Or symptoms. But again, I think you have to be very careful not to exclude options for patients that are full on refusing colonoscopy. I think it's important to realize that you have options. It may not be ideal not to do a colonoscopy, but I would want to test somebody rather than not test at all.
So Dr. Aklilu, how does, first of all, what do you look for staging? How does CEA play a role and the other image studies for colorectal cancer in your practice? And how does that really affect and change the kind of pathway for your patients?
The way to think about it, there are 4 stages of colon cancer, and the first 3 are typically treated with surgical resection up front, followed by a discussion of whether they need any further surgery later on. For those that have disease that have spread, what we call stage 4 or metastatic cancer, those are the ones that we're trying to figure out what, if any of them, one, have a curative potential, or two, what is the appropriate sequence to get them that curative potential, or what is the palliative treatment that's best for them. So when we first see a patient, we assess their physical status, their comorbid conditions, their physical well-being, their spiritual well-being. What's the help that they need to move forward with their therapy? Are they strong enough to handle these therapies? What is the help that we can provide them? We are also involved with getting the genomic profile that will help us predict and prognosticate appropriately what the best treatment for them would be to move forward. The thing I look for in the pathology, as we look for those patients in their first 3 stage, in the stage 1 or stage 2 or stage 3, really is the depth of invasion of that tumor in the colon wall, the nodal status, how many lymph nodes were involved, where these lymph nodes were placed, was there an adequate lymph node status that was present. We look for clinical parameters when they presented. Did they perforate at any time? How did the surgery go? Were there obstruction? Were they clinically obstructed when they first presented? This may help us in making decisions on what their risks are and what therapies to offer. Then we also look for radiographically, are there signs of metastatic disease, questionable disease, and their parameters, and we look at them during this period of time. And so that's where the multidisciplinary tumor board, because sometimes you can read a pathology report, but sometimes when you hear from the pathologist and you look at the images yourself, you get a different perspective of that person's tumor stage appropriately. And so I think that's where the multidisciplinary evaluation helps. Then once we see the patient with that pathology present to us, and we can talk about what their genomic profile has shown us, and then we move forward in discussing what the next steps should be. But I don't think that we should minimize the appropriateness of understanding what their comorbid conditions are and what their physical status is at that time, and maximize any nutritional or barriers to care that may be present. We also serve a large population that has both cultural and socioeconomic barriers to getting care, and so we have to understand that. Language barriers are present, cultural barriers and mistrust to medical treatments are present, and so those are the kind of things that in a large cancer center that is helpful to have on hand, that we have a nice psychosocial team that can help us understand that.
So what do you tell a patient that has just been diagnosed with colon cancer, 45-year-old female, she has 3 kids that are going to college, and that's what she's worried about, and now somebody told her that she has cancer. How do you approach that patient, Dr. Aklilu?
I go through that really carefully, and I think the first step that I do is just introduce myself and say what my role in and what they have the diagnosis with. And then as they're really just kind of worried about what it is, I go through a stepwise approach of where I describe to them where their journey is. And I find that by going through their journey, letting them hear their radiological findings, their pathological findings in a careful manner, that it sometimes slows things down. We're able to go through that journey together and just see where they are right now. And during that period of time, I try to provide some education during that period of time what that means. And during that initial things, and I've seen people who are coming here, most of them are hyperventilating at this point. And that careful evaluation and that kind of a calm tone as you're walking through that, they're hearing what they're saying, and they're just, okay, this is what I'm going through, this is what I'm going through, this is what I have, this is what I'm going through. And at the end, you really try to give them a careful evaluation in a calm and comforting tone that what they're going through is this. These are the options that you have. These are what we can expect in terms of cure. And I'm pretty straightforward with that. And I think most people appreciate that. I'd probably say there are 95% of people that want to hear exactly that. There are some people that are just scared and they don't want to hear that issue. But I think that when people hear what they have, what their steps are, and what the potentials are in terms of cure afterwards, then they move forward. The difficult conversation is when there is no chance for a cure. And what you're talking about is a palliative therapy. And then you have to really have that discussion too.
So I did still want to kind of broach this is during that first conversation, what do you tell the patient? You meet them the first time. How long is your relationship with this patient going to last? What do you tell them? How long is that initial journey? And then what about, further on down the road?
I think there's a comment here.
Dr. Shabinsky?
Yeah, well, I think that, as surgeons, we see patients with colon cancer typically right after diagnosis. Most patients have a really skewed view of what cancer means and means to them. Most of them are convinced that they're going to die probably very soon. So the first thing is to dispel the thought that this is something that's going to do them in a short period of time. The second is to tell them that they've had a growth in their colon for anywhere from 3 to 5 years, maybe longer, that a week or two to really understand their tumor, see the people that they need to see, and make an appropriate plan, that they don't have to rush tomorrow into the operating room, of course, unless there's an emergency. And again, being honest, being empathetic, being thoughtful, understanding what their goals are, being sure to elicit what their goals of therapy are. Again, a 95-year-old is going to be different than a 45-year-old. Somebody with significant medical comorbidities is going to be different than somebody who's an Olympic runner. What you have to do is dispel the rumors, start from ground zero. This is where we are. This is what the journey is going to look like. These are the people that you're going to meet along the way. And our bond is going to last for many years. Because as a surgeon, I tend to see my post-op follow-up cancer patients well into 5 and 10 years out from surgery. And do their screening, look at their follow-up, and explain to them. And even if there's little I can offer from a surgical perspective, other than support, that's important too. And also, introducing the other team members, explaining what their roles are, kind of getting them prepared for when they meet the medical oncologist, getting them prepared for when they're meeting the radiation oncologist, and also we're very involved in having integrative medicine, psychosocial support, and other areas to help support, including support groups from prior cancer patients that can help to get them to the next step. And again, I also tell them, and it's very important, you don't have to decide what you're going to do 3 steps down the road. All you really need to know is what's our next step and what's the step after that. And beyond that, we'll deal with it together.
So this is open to the panel. What do you tell your patients' survival stats? What stage 1, 2, 3, and 4? Anyone?
Well, I'm honest with them. I tell them what the survival statistics are if they ask.
So what are the numbers?
Well,
For our audience, what are the numbers for survival stats for stage 1, 2, 3, and 4?
Well, the numbers that I quote, stage 1 is essentially after resection, there's no change in life in life status. You go back to whatever your stage, your life expectancy was, nearly 100% curative. Stage 2, roughly 80%. Stage 3, roughly 60%, 5-year survival. Stage 4, depending on what stage 4 means, can be very low or as high as 30 or 40%. For example, somebody presenting with a solitary resectable liver metastasis will have a 40% 5-year survival, but somebody with diffuse liver and lung metastases probably isn't going to survive 5 years, probably has a life expectancy of 2 to 3 years.
Dr. Aklilu, what about your numbers? I usually tell them that stage 1 is greater than 90% chance of being cured. I love seeing stage 1 patients, and I love to incorporate more stage 1 patients in my practice. Stage 2 are probably the most difficult conversations that we have, I'll be honest with you. Sometimes more difficult than stage 4 conversations because overall as a group they have an 80% chance, but there are a subtype of stage 2s that have a worse prognosis than some stage 3s. And so it depends on where they are in that parameter. And then we also incorporate genomic profile in those stage 2s to have a discussion of their prognosis and their treatment options. And so when you're talking numbers and you're talking genomic profiles and you're talking about outcomes and choosing and not choosing therapy, it really requires a sophisticated patient who's able to understand numbers and understand other issues. So I find that conversation sometimes difficult when folks are not really, medical language is not their first language, which is everybody, really.
Right.
Stage 3s are the most straightforward conversation. And so I quote a number of 50% after surgery and roughly 70% after some form of adjuvant therapy. Stage 4s, we had that's very similar numbers that we talk about during that period of time. And it's not every stage 4 is a stage 4. And so that's what I think when you label somebody stage 4, it becomes an issue. Those with single organ disease. We have Nick Dallas here who does HIPEC for people who have peritoneal disease. There are other aggressive approaches with a multidisciplinary approach that we can have different discussions with. There are some people who are microsatellite instability where immunotherapy may have some wonderful outcomes now. A small minority of patients that have really wonderful prognosis, even with stage 4 disease. And so I think that's a difficult conversation, but those are the kind of numbers that I talk to.
Dr. Ruffer, radiation oncology is a very specific discipline. I think a lot of people have heard about surgery, a lot of people have heard about chemotherapy, but radiation is a little bit more specific. What is your role as a radiation oncologist, A, with colon cancer, B, with rectal cancer, and then C, with stage 4?
The answer to colon cancer is probably the easiest because it's minimal. There's very rare populations of patients that we will have a part in having anything to do. The T4 patients who may have residual disease, and the surgeon has been kind enough to leave multiple clips in the area exactly where they say there's disease left over there. Nowadays, overwhelmingly, they can get that disease, so that the role is diminished even beyond what it was previously. In the patient population with rectal carcinoma, there's a well-defined group of patients, node positive, certain patients with certain depths of invasion or low presentations, where the utilization of neoadjuvant or radiation with chemotherapy prior to surgery has become the standard of care. There has been an evolution in how we deliver the radiation and when we deliver the radiation. There was just a published study suggesting radiation at the very beginning of chemotherapy and radiation before surgery, which has been a paradigm shift since I started the treatment, and I'm sure Dr. Cheminsky started the treatment.
Well, we both started in 1990.
So in those days, we would see a lot of patients actually who would go to surgery up front. So the neoadjuvant care or the upfront chemotherapy and radiation wasn't really utilized as much in those days, or it was half and half when I trained, and I was training on the East Coast. And it's really evolved into anyone that you're suspicious for having certain criterion will get upfront chemotherapy and radiation. So because of the differences in the anatomy of rectal cancer versus colon cancer, there's much more of a role of radiation. In the population who have metastatic disease, again, the differentiation as to what types of patients those are has been made. There are patients with oligometastatic disease, and there are trials that show the benefit survival-wise of utilizing something called stereotactic body radiotherapy, which is high-dose, very focused radiation in people who have 1 to 3 or 1 to 4 areas of presentation initially. The standard of care is removal of solitary liver lesions. Oftentimes those can't be removed for a variety of reasons. So stereotactic radiotherapy has been utilized very effectively with outstanding local regional control. Radiation can be also used in the palliative or supportive, in people who are bleeding, in people who have painful disease. And even if they have metastatic disease and the primary has not been taken out and there's bleeding, we can act relatively nimbly and swiftly to treat that, to decrease the bleeding to decrease the risk that that's going to progress.
Dr. Bask, how do I order a CT scan to stage for colorectal cancer? Do I need IV contrast? Do I need PO contrast? Do I need rectal contrast? Do I need all three?
Right. So generally when you're ordering a CT for staging colorectal cancer, you're getting a full CT chest, abdomen, and pelvis. They should always be done with IV contrast unless the patient has some sort of contraindication to IV contrast. Basically, it just helps delineate multiple structures better. You can find lymph nodes more easily in the chest. You can basically pick out lesions in the solid organs like the liver that would be hard to see otherwise. So IV contrast is basically the default unless there's a contraindication to that. As far as oral and rectal contrast, so oral contrast is kind of a controversial topic, and different places do things different ways. Generally, most commonly, the routine CT abdomen pelvis will have oral contrast, basically just to kind of better delineate bowel loops, and it tends to be more useful in patients who have lower BMIs or have had prior surgeries or things like that. Having said that, there's a growing trend to tone down the use of oral contrast, but generally, if you order a CT chest, abdomen, pelvis, the patient will usually get oral contrast. Rectal contrast has really no role in these patients. We're not trying to evaluate the rectum or the colon primarily. We definitely get some information about the primary tumor in the colon from the CT scan, but the real role for the CT is for staging for nodal disease and distant metastases, and not trying to delineate the specifics of the primary mass. So yes, IV contrast, often PO contrast by mouth will be given, but rectal contrast is usually not.
What do you tell patients with recurrent colon cancer, Dr. Aklilu, about their chances of, conquering this?
Sure. If I can make a quick comment about the issues of the radiographic abnormality on people who are on surveillance. I think it's really important to recognize that not every abnormality on a CT scan means that that person has recurrent disease. And so it's really important to have a careful evaluation of what that abnormality was, what does it look like, and what our true concerns are, what are the probabilities that it's real. We also have to recognize that though PET scans are wonderful modalities, I think that they are overused. Not everything that lights up on a PET scan is positive. It means that it's cancer. Or not everything that doesn't light up doesn't mean that it's not cancer. So it's really important to have an appropriate clinical evaluation, a pretest probability of what we think that is, so as we move forward. And so, again, patients are so obsessed with their findings of their CT scans. And now that we have these electronic records where people have access to it and they see their CT scans before they even talk to us, radiologists have to mention every abnormality that's present, right? And so you require a good understanding of what that abnormality is. And so it's really important to recognize not every abnormality is cancer, and so I think that we have to kind of temper down that issue. But when people have true recurrent disease, it's really a matter of where this recurrence is. One, do we think that it's a local recurrence, or is this a sign of failure? What type of failure is this? Is this a failure that is a curable failure? Or is this a failure that's a sign of an incurable path? Or is it a question mark that with treatment it could become curable? And so what we tell them and what we offer really depends on the site of recurrence. Is it a solitary recurrence versus a sign of something else that requires further research? And it also depends on what prior therapy they have, what their reactions to prior therapies were, and what their present conditions are right now. That kind of makes that discussion. And so those are all the kind of things. I think not every recurrence requires pathological confirmation. I think we biopsy way too much sometimes, but there are times where I think it is appropriate when there's question marks or if there's a long period of time that's left over. And so those are all the questions that we talk about. Do we think this is a recurrence? Is this a solitary recurrence? Do we need to search for other things? Do we need to prove that this is a true recurrence with a biopsy? would that biopsy help us know what further genomic profiling to do in this patient to see if it has changed from previous profiles? Those are the questions that we really ask.
And is there a role or special techniques or different things that you do, Dr. Weisenberg, for recurrent colorectal cancer when you look at this from a pathology standpoint?
That sort of depends on the clinical setting, and we would work hard with medical oncology to determine that. Sometimes tumors will change over time, and the molecular profile may change, so there may be differences in what treatments may be indicated. Sometimes it's just want to, before a patient goes to hospice, we just want to make sure that indeed the lesions that are in question are indeed cancer. So it's a joint decision, and we will do what is in the best interest of the patient.
I want to ask one last question for all of our panelists is, from your specialty, what's the one takeaway point that you want our audience to know about colorectal cancer? Dr. Albert.
So I was actually thinking about that, and frankly, I'm in awe at the work that my colleagues do to help people live better lives once they're diagnosed with colon cancer. I think it's amazing work. What strikes me is the piece that's preventable, and that none of this conversation would have to happen if we could just do better at preventing colon cancer through screening, and that's where it begins. So although we have all these experts here to help patients once they're diagnosed, the question is really, how can we avoid that conversation, that first conversation, that journey that Dr. Aklilu was mentioning in the first place? That's something to think about. And I would encourage clinicians to please talk to your patients about the different ways to get screened before this conversation progresses and they do take that journey.
Dr. Stravinsky?
Well, I have two messages. The first is I can't overemphasize enough the importance of a multidisciplinary team that evaluates these patients to come up with an appropriate treatment plan. And second, when a patient has cancer at whatever stage, they'll always assume that their prognosis is worse. And it's important to get them into the hands of those people who deal with this on a regular basis to have the appropriate discussion and lead them on the appropriate path for treatment.
Dr. Weisenberg, what is your one takeaway for our primaries?
Well, when you get a pathology report, it is not carved in marble. It is written on paper or made in electrons. So if you have any questions, you have any concerns, communicate with the pathologist. We can addend the report, we can amend it, but don't just say that's the way it is. And, we're not, part of our job is also to educate you about what we're trying to convey.
Thank you. Dr. Aklilu, what's your one takeaway point?
If I can give kind of 2 points. One, to echo Dr. Albert's point, is by the time you see me, we have failed you. And so it's really important not to see me, as I always say that. The other issue that's really important is that whole process of cancer survivorship that we forget, how truly important it is to have physical well-being. That issue is that maintaining a BMI, a good diet, non-sedentary lifestyle, exercise are so important in helping reduce the risk of cancer recurrence. I always have that, what I call my cancer survivorship discussion when we finish therapy and we go through those points together. And I always go through them, but nobody really follows. It's a minority of patients that follow that discussion. And it is so important. And sometimes the magnitude of that importance is just as much as chemotherapy for some patients. And so if I can have a partner in the primary care world that can help me adequately maintain their comorbid conditions, help push physical wellness in that cancer survivorship realm, that'd be nice. That'd be nice.
Great. Thank you, Dr. Aklilu. Dr. Ruffer, what's your one takeaway point for our audience?
I'd actually echo Dr. Stravinsky in regard to the importance of the multidisciplinary approach. And it's actually, I'm going to tout a lot of the folks up here, the importance of the knowledge base, but the importance that I see every day in the people up here and the emotional intelligence, the empathic intelligence and the importance of the teamwork and reaching out to the people who are actually watching this. Part of the team is the primary care physician, because you're the person who long term is going to be seeing that person the most. We will continue to follow, obviously, long term, but it's not just the folks here or the folks in that clinic. It's you who's actually watching that person long term and making sure if there's any issues that we remain involved and we make sure that we keep you involved.
Great, thank you. And Dr. Boss, what is your one takeaway point?
So I think on the one hand, a well-ordered radiology study in the proper clinical context after appropriate discussion with the team and according to recommendations and guidelines can be extremely powerful, can change the trajectory of a patient's management and make sure that they're getting the best outcome. On the other hand, you don't want to be a poorly ordered radiology scan can be kind of dangerous and can give you a false sense of security. So what you want to do is just be careful about what you order. If someone has a negative CT abdomen pelvis, that does not necessarily mean they don't have colon or rectal cancer. And a great resource for both primary care physicians and specialists is the ACR appropriateness criteria. It's the American College of Radiology. It's a free online resource where you put in the clinical situation and they give you a list of the appropriate exams to order and why, and likewise which exams are not appropriate. And I point all of my primary care colleagues to that resource for this disease and others.
Very well. Thank you very much. I would sincerely like to thank all of our panelists for taking the time and energy and effort to really educate our audience at Advocate Aurora about colorectal cancer. Thank you very much. And thank you to the audience for your partnership with taking care of your patients. We'll take any questions. Thank you.